Hi, my name is Cassandra Chiao. I am one of the first-year nephrology fellows, and I am very excited to share with you this whodunit you never asked for: toxic alcohol ingestion and the kidneys, which takes inspiration from murder mysteries like the story Clue. So why am I doing this? Well, first of all, I really love murder mysteries. I love whodunits. But more importantly, I have heard several times now that we don't seem to talk a lot about acid base. And also, I recently missed a potential toxic alcohol ingestion. So that got me thinking about the topic a bit more, and was the inspiration for this talk. So you are a detective this morning. You are called to come here to the classic Clue mansion because someone's been found down. Not a murder yet. You walk in and you find this person awake but poorly responsive. They're surrounded by this questionable looking fluid originating from this fallen chalice, and it comes to you. It was poison. But what kind of poison? And who did this? So you gather everyone in the house. You have some of your classic Clue characters: Mrs. White, Mrs. Peacock, Professor Plum, and Colonel Mustard, and everyone is a suspect. So you lock all of them in the house, and you bring the patient, of course, to Harborview. So there, you find out a little bit more about the patient. She's actually a 49-year-old female, unknown past medical history. On her vitals, she's a little tachycardic, a little tachypnic, but otherwise hemodynamically within normal limits. You get some labs, and things are looking pretty abnormal. You know, that bicarb is 8, the anion gap is 30, little AKI, pretty acidemic, and the osmolar gap is 21. So that gets you thinking, maybe this is a toxic alcohol ingestion. And if so, do we need to dialyze? All right, so I promise you that by the end of this, we are going to know what the poison was and who done it. But before that, this is going to be how we're going to work through the rest of our time together here. So first, we're going to start with a history lesson in extracorporeal treatment, otherwise known as dialysis in our modern day terms, for poisoning. So back in the 1800s, our father of modern nephrology, Thomas Graham, first developed the principles of dialysis. Then in 1913, the first artificial kidney was created. And interestingly, the purpose of this was to remove salicylates from the blood of a living animal. About a decade later was the first successful dialysis in humans. 2 decades later, the first reported dialysis in a human for salicylate poisoning. A couple years later, several other poisons were found to be dialyzable, including barbiturates and hypnotics. Then, as we all know very well, in 1962 was the establishment of the first outpatient dialysis center in the world, right here in Seattle, Washington, the very year of the Seattle World's Fair. And the point I'm trying to make here is that dialysis was actually used as an antidote for poisonings before it was used regularly for ESRD. All right, so some brief basics. You all know about metabolic acidosis and how to calculate an anion gap. And most of my time today will be spent talking about the high anion gap metabolic acidoses, where there's something causing the acidosis that's also throwing out these extra anions, unmeasured anions. And when we see this, it clues us in that there's something amiss, something that we need to find that is causing this acidosis. And typically we use this acronym GOLDMARK when we're thinking of our differential diagnosis for these. And I think it's interesting that 4 of the letters in GOLDMARK represent ingestions. The other very brief thing I want to touch on is the osmolality gap. So as you all know, we calculate this by getting the measured osmolality minus the calculated osmolality. And if that number is greater than 10, it clues us in that there is something else in the bloodstream that's osmotically active, and that something could be a toxic alcohol. And the other small point that I want to make about measuring osmolality is that most places use a freezing point depression to measure osmolality, which is the best way. There is this other way you can do it that's called the vapor pressure osmometry. If you are looking for a toxic alcohol, you cannot use that because the volatile alcohols will be evaporated in the process of making this measurement. So of course, here at our labs, we use freezing point depression. Okay, so getting into our toxic alcohols, I will say that I will be spending the most time talking about methanol because I will be speaking on a lot of very foundational concepts that do apply to the rest of them as well. Okay, so starting with methanol, which importantly is the toxin of choice of Mrs. White. Methanol is a byproduct of grain fermentation. And the main sources of methanol generally come from kind of car-related things, most commonly like windshield washer fluid, but also kind of famously adulterated ethanol or moonshine. So in terms of prevalence of methanol poisonings, it does seem to happen a lot more in other countries. And there is this kind of funny Wikipedia article that's literally called The List of Methanol Poisoning Incidents. And it's just this list of 27 countries in kind of every continent except Antarctica. It just has like little snippets about how like up to thousands of people have died, unfortunately, from usually methanol tainted alcohol. But don't want you guys to think that this has never been a problem in the US. So during the Prohibition, the US government was actually endorsing the use of methanol as a denaturing agent in industrial alcohols in an attempt to discourage people from drinking. And unfortunately, people were not discouraged from drinking, just a lot of people died. So not great. But moving forward, so this is the metabolic pathway for methanol. And as you can see, there are two main enzymes that are important in this process, alcohol dehydrogenase and aldehyde dehydrogenase. And you will see these enzymes come up in the other toxic alcohols as well. So methanol becomes formaldehyde, which then becomes formic acid. Methanol can be detected on what we call the volatile screen on our lab tests. And in terms of symptoms, the classic symptom is this first decreased or blurry vision, which then can lead to blindness. And it is the formic acid that is toxic to the optic nerve that causes this symptom. Other symptoms include, good old abdominal pain, and also, unfortunately, Parkinson-like features as well. Now, it's important to note that it is the formate that is causing the high anion gap in this situation. And then the high osmolar gap is caused by the methanol itself. And you may notice here that there's going to be a time difference in between when there is more methanol in your bloodstream and when there is more formate in your bloodstream. And this is an important concept that will pertain to the rest of the toxic alcohols as well. So I do just want to take a little detour here. So it's the toxic alcohol, in this case methanol, that is causing your elevated osmolar gap. And again, it is the formate that is causing your high anion gap. So depending on when you are testing for these things in relation to when the alcohol was ingested, either of these things may or may not be elevated. They have an inverse relationship with each other. So shortly after ingesting the toxic alcohol, that is when your osmolar gap is going to be the highest. As the alcohol is being metabolized, your osmolar gap decreases. And as you are developing more formate in the case of methanol poisonings, then your anion gap is going to increase. So they have an inverse relationship. Now, interestingly, if you co-ingest with ethanol, this kind of accentuates the curves a bit more because, again, you're adding something else that is also kind of contributing to the increased osmolality. So again, this is a very important concept that also applies to many of the other toxic alcohols as well. Okay, so back to methanol. So we have a couple of treatment options for methanol. So the first is sodium bicarbonate. This is a great option. It corrects acidosis and it increases its ionization of formic acid and promotes the urinary excretion and therefore decreases optic nerve penetration. Alcohol dehydrogenase inhibitors, such as fomepizole, also a great option. Fomepizole, particularly, is a strong inhibitor of alcohol dehydrogenase with very high enzyme affinity, about 8,000 times that of ethanol. Fomepizole doesn't have any serious side effects, and you do not need to be monitored in an ICU solely for fomepizole use. Folic acid, yes, this is great as well. Formate converts eventually to carbon dioxide and water through the folate cycle. So actually giving folic acid will kind of help that process along. And what about gastric decontamination? The answer is no, it's not helpful because the absorption of methanol in the GI tract is so rapid. All right, so then what about dialysis? When do you dialyze for methanol poisoning? So before I answer that question, I want to take a step back and actually talk about what makes any toxin dialyzable. So a couple of things to think about. The first one is molecule size. So in general, you got to be small. Don't have to be as small as before we had our high flux dialyzers, but in general, a molecule has to be less than like 10 to 14,000 Daltons. In terms of our toxic alcohols, methanol, for example, is like 32 Daltons. And the rest of the ones I'm going to talk about are definitely less than 100, so we're good there. In terms of protein binding, this kind of gets into molecule size as well. You know, if something is bound to a protein, it's going to be too big to fit through the pores of the filter. But interestingly, even some toxins that are highly protein bound, like salicylates and valproate, once the protein binding sites are saturated, then you can actually have a lot that's freely unbound, and then all of that is dialyzable. Endogenous clearance gets into how quickly the toxin is kind of cleared on its own in the body. So for example, cocaine is cleared very quickly and is thought to not be dialyzable. And I've read that something is only thought to be like worth it to dialyze if dialysis makes up at least 30% of the total clearance of the toxin. And the last thing is the volume of distribution. So of course, you can only dialyze things that are in the vasculature. So things that have a high volume of distribution, you know, that go extravascularly, things like tricyclic antidepressants are not considered to be dialyzable. So when it comes to our toxic alcohols, they check all 4 of these boxes and they're indeed dialyzable. So moving on to methanol, and when do we dialyze? So all of these recommendations come from XTRIP, which is an extremely important resource to know about. XTRIP stands for the Extracorporeal Treatment in Poisonings Work Group. And this work group was established back in 2010. They review the literature and they give recommendations on how to manage different types of poisonings, particularly with the use of dialysis. They have a great website, very user-friendly. So I don't think you need to memorize any of these, but just know that XTRIP is a resource and all of this came from there. So when you dialyze for methanol poisoning, essentially, if anything that's obviously very bad has happened, things like coma, seizures, vision deficits, you know, severe acidemia, dialyze then. But also, you know, if you have you know, super high anion gap, persistent metabolic acidosis, impaired kidney function, you know, these are all reasons to dialyze as well. And while you are dialyzing, the recommendation also is to continue fomepizole if you have already been giving it. Now, the other point about fomepizole and dialysis is that fomepizole increases the half-life of methanol very significantly. So this is the first article about fomepizole and the use for methanol poisoning. This is New England Journal of Medicine back in 2001. And In this study, they found that fomepizole actually increases the half-life of methanol to 54 hours, and its typical half-life is like 14. So here they were kind of saying, even if someone doesn't have kind of the typical or like urgent indications for dialysis, dialysis might actually be warranted anyway, just to prevent a super prolonged hospitalization in patients with very high plasma methanol concentrations. So then when do you stop dialysis? So per X-strip, the dialysis can be stopped when your methanol concentration is less than 200 milligrams per liter and you see clinical improvement. Well, you may be wondering, how long will that take? So methanol and some other toxic alcohols are eliminated kind of through first order kinetics. So you can use this kind of complicated equation to figure out the time it would take to eliminate this. But I have seen some studies that have created these prediction models of how long it would take on dialysis, depending on the initial methanol concentration in the body. And it does seem that the upper limit of time is around like 12 hours. So it probably won't take more than 12 hours. And the other important point to make here is that in terms of the modality of dialysis, intermittent hemodialysis is going to be a better, more efficient option, of course, than CRT or even your own kidneys. So if you have the option where the patient can tolerate intermittent hemodialysis, that is the one to pick. Okay. So we made it through methanol, and next is ethylene glycol. So ethylene glycol is the toxin of choice of Mrs. Peacock. And the main sources of ethylene glycol are antifreeze and engine coolants. And this is the metabolic pathway for ethylene glycol. It first becomes glycoaldehyde and then glycolic acid, where the glycolate is that main unmeasured anion in the high anion gap metabolic acidosis. The glycolic acid then becomes oxalic acid, and it's the oxalate that combines with calcium to create that calcium oxalate crystalluria, then leading to AKI, usually 40 to 72 hours after ingestion. Some other symptoms of ethylene glycol poisoning are inebriation and also cranial nerve damage. So as I was saying before, you get that high osmolar gap, from the ethylene glycol itself, and then you get the high anion gap from the glycolate. That inverse relationship between these two still applies. All right. So in terms of diagnosis, unlike methanol, ethylene glycol is not seen on the volatile screen, which uses gas chromatography. But we do have other clues that we can use to figure out if there was ethylene glycol poisoning. So the first is a discrepancy between lactate and LDH. So lactate is measured or tested by a lactic oxidase reaction that can't distinguish between lactate and glycolate because they have just a 1-methyl group difference. So if you see a really high lactate, but a not so high LDH, that can clue you in that ethylene glycol was involved. The second thing you can try is to use UV light or Wood's lamp on urine to see if it glows, because automotive antifreeze usually contains fluorescein to detect radiator leaks. However, other things fluoresce in the urine as well, things like phosphorus. And then the last thing is you can look for oxalate crystals in the urine, but of course, this is totally not specific. So really, the definitive testing for ethylene glycol is to use high-performance gas or liquid chromatography. And at our labs, we use that high-performance gas chromatography. It's labor-intensive, it's expensive, and results can take several hours or even days. And here, it takes several hours. All right, so in terms of treatment, similar to methanol, bicarb and ADH inhibitors like fomepizole, yes. Gastric decontamination, no. And then again, in terms of when to dialyze, these recommendations are taken from X-strip. You don't need to memorize this, but again, in general, if the osmolar gap is very high, like above 50, even in the setting of fomepizole, dialyze. If you don't have that option to use fomepizole or another ADH inhibitor, then dialyze if the osmolar gap is greater than 10. Also, if the anion gap is super high over 27 or there's kidney impairment, dialyze then as well. And again, all of this is available to you on the XTRIP website. In terms of when to stop dialysis, XTRIP recommends when your anion gap gets less than 18 or when your ethylene glycol concentration gets less than 25. Again, in terms of how long that will take, you can use this kind of complicated equation to figure out the exact timing. But I have also seen other prediction models try to figure out the number of hours it would take on dialysis, depending on the concentration of ethylene glycol in the bloodstream to begin with. And the kind of upper limit of time seems to be 16 hours. So probably no more than 16 hours at most. And then again, intermittent hemodialysis is the best, most efficient option for treatment here. If you have the option, choose intermittent hemodialysis. Okay, so next is propylene glycol. Propylene glycol is the toxin of choice of Professor Plum. And the main source of propylene glycol that we'll see is as a diluent in our infusion medications. So the big one is lorazepam. If you run it at 10 milligrams an hour for 48 hours, that puts you at kind of higher risk here. And that is about 40% propylene glycol. Excuse me. This is the metabolic pathway for propylene glycol. Of course, our same enzymes are involved here. Propylene glycol becomes lactaldehyde, which becomes lactic acid. Interestingly, both D and L lactate. Symptoms, usually you just see an increased osmolar gap, but sometimes you can also see lactic acidosis and AKI. So you see a high osmolar gap and sometimes a high anion gap. In terms of treatment, toxicity is generally low, but if you do see a high, if you do see hyperosmolality and lactic acidosis, just discontinue the medication and give IV fluids. So last, we have isopropyl alcohol. Isopropyl alcohol is the toxin of choice of Colonel Mustard. Its main sources are rubbing alcohol, hand sanitizer, and some of these people will try to inhale it or use dermal or rectal routes and that sort of a thing. This is the kind of pathway of metabolism for isopropyl alcohol. As you will see, it is simpler than the other toxic alcohols. Alcohol dehydrogenase will turn this into acetone. As you will see, there is no metabolite that contributes to acidosis in this case. Isopropyl alcohol can be detected on a volatile screen. And in terms of symptoms, usually you get some inebriation, depressed sensorium. You can get acute pancreatitis from it, as well as in the worst cases, cardiovascular and respiratory collapse. So with isopropyl alcohol, you do see a high osmolar gap, but a high osmolar gap, but a normal anion gap. So then in terms of treatment, usually supportive measures are sufficient. Intermittent hemodialysis has been recommended when the serum concentration is really high, like above 500. And of course, if the patient is like hemodynamically unstable from the isopropyl alcohol. But in contrast to the other toxic alcohols, alcohol dehydrogenase inhibitors are unnecessary because the metabolites are not associated with any acidosis or significant end organ toxicity. Okay, we made it through all of the toxic alcohols, but who done it? All right, so getting back to our case here, back to Harborview, our patient here with excuse me, a high anion gap metabolic acidosis, an increased osmolar gap. We're concerned about toxic alcohol ingestion. So we get some additional information here. The UA is showing oxalate crystals, the volatile screen is negative, and the urine fluoresces with Wood's lamp Dun, dun, dun. It was ethylene glycol. And the patient does meet criteria for dialysis based on the extra criteria. So gotta consult nephrology for dialysis as well. And maybe most importantly, because we know that ethylene glycol is a toxin of choice of Mrs. Peacock, back to the house to arrest Mrs. Peacock. All right, so for our summary here, number one, remember that there is an inverse relationship between the osmolar gap and the anion gap. Shortly after ingestion of the toxic alcohol, that is when your osmolar gap will be the highest. And then as time passes, your anion gap increases. Number two, in terms of what makes a toxin dialyzable, you got to think about the molecule size, protein binding, endogenous clearance, and volume of distribution. Number three, intermittent hemodialysis is going to be the best option, most efficient option for treatment. Excuse me. Number four, fomepizole and sodium bicarbonate are excuse me, so sorry. Fomepizole and sodium bicarbonate are excellent options for treatment in addition or before hemodialysis. And number five, X-Strip is a wonderful resource to use in these scenarios. Okay, so lastly, I want to give a special thanks to Dr. Sangavi, Dr. Hall, Dr. Corolla for helping to refine my presentation. Thanks to my husband, Dr. Stample, for offering his expertise in emergency medicine and critical care on this topic. And thank you to my incredible co-fellows for inspiring me every day. And actually, it was a conversation on book recommendations a number of months ago that got me talking about my new favorite murder mystery series that inspired me to make that the backdrop of this talk. And I appreciate all of you kind of humoring me in this process. So thank you, everyone.
Thank you, Cassandra. Gorgeous presentation on a classic nephrology topic. Looks like a question from Leah.
Cassandra, that was beautiful, but I'm actually a fan of Colonel Mustard myself. Just a quick comment and a question. So a comment is just to make sure everyone knows that fomepizole itself is dialyzable. And so it needs to be given every 4 hours while you have someone on a machine, whether you're doing HD or CRT. So the antidote is also removed, unfortunately. And, I think one of the things we struggle with most, or I do, is how long to keep these people on dialysis, because the turnaround time for ethylene glycol levels is, often a couple of hours. And do you think it's enough to look at closing of the osmolar gap and decide to stop dialysis at that point? Or to take a defined time, like 8 hours or 10 hours, or how long do you think we should dialyze for? Or should we just keep on the machine until their ethylene glycol level meets criteria for X-Strip to stop dialysis?
Yeah, so for ethylene glycol specifically, X-Strip does say after the gap is less than, I think, 18. But they say that plus when the ethylene glycol concentration is less than 25. But you're right, ethylene glycol testing can take, hours to come back. So I think it would make sense to go by, the anion gap and, closing of the osmolar gap. And if clinically it looks like they're improving, I think that would make sense.
Okay. And my mentor, Pat Fleet, used to talk about the hyperemia that you get in the retinal blood vessels in methanol poisoning. But I have actually never seen, I don't think we've had a methanol poisoning in over a quarter century at Harborview. It's very unusual. We've had plenty of ethylene glycol. So. That was a wonderful talk.
Thank you.
Plenty of plaudits in the chat. Anyone with any final questions for Cassandra? I think we'll move on for time. Thank you so much.